This segment demonstrates some strategies for encouraging active learner participation, including inviting learners to pose questions, using silence to draw out responses, paraphrasing and restating learner responses to ensure that other learners can hear and understand, validating helpful insights and responses and encouraging others, sharing responsibility for learning with learners, and linking learning to past practice experiences.
If there's something that's not clear, something I need to explain, and if I don't know the answer, then my colleagues here probably will. Just by show of hands, who's seen recently dimenhydrinate or Gravol being used for opioid-related nausea? Just by show of hands. Okay, some hands going up. Okay, and what's another advantage of metoclopramide and domperidone? Can anyone think of it? So if I say artificial hydration, what do you feel? What do you think about it in the context of palliative care? Exactly. So it depends on how long the patient has to live. So let's think about it. Okay, what are the potential downsides of hydration? Sorry? Can prolong life. So in some people they would be inappropriate, in others may be appropriate. Okay, so it can prolong life. Can aggravate congestion. Can aggravate edema in some patients. Any other questions around or comments?
In some cases, in residential care, especially on the dementia care unit, and for somebody who's in extreme, like she's in severe pain, and she's not taking anything by oral, she's spitting it out. Sometimes that's the only route.
He describes himself as a not very religious person, but very spiritual. He experiences God in nature. Prayer is important to him and a source of peace in his life. He has discussed DNR before and is willing to discuss an advance directive. He is in the process of updating his will.
Oh, I thought you were talking about codeine percentage. You were talking about Tylenol 3.
Yeah, I was the person who prescribed the naproxen and the Tylenol 3 that they read out. And so I would still stick with the naproxen, I think, and just watch his GI and his renal function, and then either add a codeine.
So let's come back to that, okay, the NSAIDs, because I think it's worth just a little bit of a discussion, because I think there's a lot of uncertainty about, I think NSAIDs are very useful, but there's some uncertainty in terms of the evidence, and we can talk about that. Okay, would anyone start with the stronger opioid? Janet, you would? Okay, yeah, and which one would you go with?
I would go with the minus the 5 milligrams of morphine every 4 hours. Because you look at his pain, and he's already saying it's 7 out of 10. Pain in his hip is 6 out of 10. This is quite high. And then he's trying. I mean, even I have a home care background, so we're looking at people that are at home, trying to carry on a normal life, dealing with their day-to-day living, and they've got all this pain. So.
Yeah, I think it's very appropriate to go with a strong opioid. But what Nat just said was very important, is that it is appropriate going with the second step, but you monitor, and as you're going to do the next day or 2 or 3 days later. Some of those patients will do fine, and their pain will be well controlled. But if Nadia's seeing them on a regular basis, then she'll say, okay, if this is not working, okay, let's go to a stronger opioid pretty soon. So if you go with a step 2, the important thing there is that you reassess. You always reassess regularly, whether you're on step 2 or step 3. But you know, you probably lower the threshold in terms of going from a step 2 to a step 3.
So think back to the assessment. What were some, we just talked about it.
The alcohol.
Yeah. So that's one thing that you definitely want to be talking to about.
He's a diabetic as well.
With the adjuvants, a lot of the patients, they're end stage, so they're not going to eat a lot. So with those medications, you have to eat food, and a lot of the times that they can't tolerate taking food with their medication. So wouldn't that,
Is Fred really end stage right now?
No.
So it would be a reasonable thing for Fred, right? But you're absolutely correct, and we all know that as we get closer to end of life, some of those other medications or the cups of vitamins that people are taking or those kind of things. You just...
How do you define end
How about
stage?
Betadron? You said, or therapies.
Anyone had any experience with bisphosphonates for bone pain?
We use the IV, the quadrinate and comedronate.
That's right.
And we give just a single dose, and a lot of patients are on it monthly.
Right.
I've used oral quadrinate, but that doesn't seem to be tolerated well, and I don't think it's
Absolutely.
absorbed very well, so we don't
Exactly.
use that.
What about the nasal calcitonin?
Good question. Okay, because when would you use nasal calcitonin? And there's good evidence to support it.
I don't see that population a lot, so to be fair, I've never used it, but if I remember correctly, I think it was for fracture.
Exactly. Osteoporosis-related bone fractures.
That was pretty awful. What would you have done? Anything that you can think of that you might have done to improve things? I think first of all, we'll sit eye to eye. And we'll ask, how are you feeling? And that would be a nice thing to say, wouldn't it? Anything else? Pain. Yes, that's right. And what's that doing? That's showing an interest in the patient, isn't it?
And also to get a sense of whether that's going to be a good time to talk about stuff. I mean, if he's nauseous or he's in pain, then I mean, so it's like, that's not going to be that.
Absolutely. You can't talk about touchy-feely stuff if somebody's in pain.
Right.
Or they're nauseated. You're absolutely right. Anything else that you might do? Everybody here would do better, I know that.
Shake hands, just a touch.
Shake hands, that's right. Maybe even hold his hand if you know him well enough and you have permission.